Hi everyone, this is Holly from Critical Care on Your Team, and I want to talk about the dreaded DNR. And this is probably going to have to take a couple of videos because it has multiple elements to it. But one of the elements that really needs to be initiated is what a DNR is and what it is not. What it is not, we don't do anything. Okay, what it is not is a giving up. What it is a recognition that there's a certain point at which everything that could be done to keep you from getting to a certain part called a code, especially a code blue in the adult ICU or critical care setting, or in the hospital or wherever. The treatments that need to be done in order to keep you from getting to a code blue state have failed. Okay. And then the question becomes, how heroic do we want to be, and what is the end in sight? And this is where it starts getting there's multiple facets to it. If you are a person that is healthy walking on the street and you keel over and you stop breathing and your heart stops beating, and we want to resuscitate you, that is where you are a full DNR. We want to bring you back to walking on the street. If you are in and out of the hospital, or if you come in and you have a major disease process going on, let's say, for the sake of just ease, cancer, and you take chemo and you have a bad reaction, and now you are coding, you have a code blue. Well, it's fine. We can bring you back. We can try to bring you back. And with a code blue and all the things that we would do when you are a full resuscitation as opposed to a do not resuscitate. But we do not fix the cancer. And that's the problem, is that if you came to the hospital for your heart, for a stroke, for diabetes complications and sequelae, for whatever would bring you there, and you end up in a place where you need a code blue, you have to ask yourself, is this a place that you really want to be saved from? Because we are bringing you back for you to have to do this again, and maybe sooner versus later. And what I mean by doing this again, I mean the intubation with the tube down the throat, chest compressions, shock, to stop and then restart the heart. To stop the heart and then allow the heart to reset, if it will. Sometimes it doesn't. But all these things are done as a last-ditch effort in trying to correct some very, very minor things and give you another chance. But when you come in with cancer, let's say, we're giving you another chance to what? To what extent? Are we willing to go through all of this again, knowing that you're going to suffer however long with cancer, and then to turn around and still not survive very well? So, there comes a point at which, to say that the DNR doesn't stop treatment, which it doesn't, it doesn't also fix what brought you here. So once you wrap your head around that, you have the beginnings of understanding of, okay, what is it that we want to do? And if I get to a place where it looks like I'm not going to survive this, or this is a very poor prognosis and me being able to return to some functional life, honestly, I don't want you to be on my chest. I do not want electrical current surging through my body. I do not want to have a tube down my throat, especially if the outcome is not going to change. So, you can always ask for that education prior to you getting into the hospital. Some of it comes in the form of an advance directive. And all that advance directive says to us, and this is really a whole whole nother video. So actually, I think I'm going to stop there. But you do have ways in which to have your code status discussed, understood, and following you throughout your course of care. So, like for instance, I am a do not resuscitate, and I recognize that there is some limits to that, meaning that if I am choking, I'm going to want Heimlich done. I'm going to want, if I need to be intubated and it's a short period of time and I'm going to get over it, I am going to want to be resuscitated. But if I'm hit, in a car accident and it's a major car accident and I have fractured ribs and I am bleeding all over and I'll probably not be eating my food normally for the rest of my life, honestly, yeah, I don't want that. So, um, you can discuss this with your family and have it down on paper before you even get to that place. We like to think that we live forever, and we don't. We like to also think that we have until we're 80, and we don't necessarily. Um, life, we must live life on life's terms, and that means day by day. And honestly, every single time you walk out of your house, you assume some level of risk. And in that risk, there's an inherent chance for dying. And that's just reality. I'm not trying to be bleak. That's just the way it is. I've seen it. So anyway, we'll discuss this more. I know that there's other information that go along with it because DNRs are not just cut and dry. You must be do not resuscitate or full treatment. You actually have different things that you can say yay or nay to, and a lot of those things are determined by the family's previous experience and the patient's previous experience. We have a lot of times that patients have been intubated and they say, oh my gosh, that was the most terrible experience ever. Don't ever intubate me again. I mean, I'd rather die. And literally, we put them as a limited code, and we will not put the tube down their throat. Of course, if they get to a point at which that's kind of what they need, then they have just bought into the reality that, that might just kill them. But anyway, people's convictions are what they are, and people deserve to be able to know what they're getting themselves into. Heavens knows we got to sign a consent to have our toenails cut. I mean, or whatever else in the hospital. But yet at the same time, here you can go saving my life, killing me in the process, and I don't have to sign a darn thing. That is the status quo, is to save your life. And if they don't know, then it's a go, go, go type of thing. Anyway, let me know how you feel, and we'll talk about this more. Take care, guys. Stay healthy.